Ladies and gentlemen. I see that you enjoyed yesterday the party because number of people or attendees is less than yesterday and the day before, but I hope that some people will come. And I also want to apologize Atul Verma, who had some serious problems, personal problem to come. And he sent his pre-recorded lecture. I also would like to apologize my co-chair or my co-director Peter Neuschel, who will stay in Homolka Hospital, and he will have lecture online from that place. I will not chair here. So that's update. And we can start with a talk of Atul Verma from Montreal. All pulse field platforms are not the same. The impact of waveform on biological effects.
Thank you very much for allowing me to give this second talk at the 2025 Prague Rhythm Conference. Again, I apologize that I wasn't able to be here in person, but very, very happy to be involved. These are my relevant disclosures, and I want to acknowledge that some of this data comes from the preclinical R&D team at Abbott. So, as you know, pulses are very, very complex. There are a huge number of parameters to optimize. I think the key things that you really need to understand, obviously, are bipolar or unipolar delivery, the voltage, but in particular, the pulse width is very, very important, and I'll be going into that in a little bit more detail. But just for your information, the typical parameters that are being used by most of the systems are as shown here, and you can see that most of the systems are really working in the 1 to 10 microsecond duration. In fact, it's probably closer to 1 to 5 microseconds. As you know, there are a number of items that are components of the pulses. There's a positive wave, a negative wave, there's an interphase delay, and then there's an interpulse delay, and then a bunch of pulses put together are called a train, and there's an intertrain delay. So pulse width is actually one of the key parts of this recipe. And if we look, for example, at the pulse width, just going from 1 microsecond to 2 microseconds, I was absolutely astounded by how much of a difference this could make in terms of the depth of the lesion produced. Down here at around 1 microsecond, you're getting about a 3.8 millimeter deep lesion. And once you get to about 2 microseconds, you're now getting in the 6 millimeter range. I mean, that is a huge difference in terms of efficacy just by changing the pulse width from 1 to 2 microseconds. Furthermore, we know that we want to minimize musculoskeletal stimulation. And again, take a look at this. Just going from 1 to 2 microseconds, we go from what we would consider to be acceptable levels of MSK stimulation to levels that are completely unacceptable in the clinical scenario. So you can see how we're trying to go for the deepest possible lesion, but we also have to mitigate against musculoskeletal stimulation. Now, the shorter the pulse width, the less likely you are to get musculoskeletal recruitment. So when people talk about going into nanosecond deliveries, they're really not going to necessarily increase the efficacy of PFA, but by going into nanosecond type ranges, you certainly reduce the amount of skeletal muscle reaction that you get. And also remember that some of the systems that are saying they're nanosecond delivery are actually not true nanosecond delivery. There's several hundreds of nanoseconds, so they may be 0.5 to 0.7 of a microsecond. And the reason why efficacy is not necessarily better is because as you start to reduce the pulse width, you need to dramatically increase the voltage to get the same area under the curve and to have the same therapeutic effect. So keep in mind that going into nanoseconds has some advantages, but doesn't necessarily improve your efficacy. Now, I know that the next speaker is going to be talking a little bit about hemolysis. His whole talk is on hemolysis, so I don't want to talk in detail about this, other than the fact that in addition to release of plasma-free hemoglobin, I believe that release of myoglobin is also playing a role. So we see incredible elevations in myoglobin. And keep in mind that this is a 24-hour level of myoglobin rise. So if you understand the kinetics of myoglobin, if we are at this level at 24 hours, that means our peak myoglobin level must have been so high that it's similar to a large anterior MI after ablation. And I'm not saying that myoglobin is necessarily what causes the renal injury, but if you combine myoglobin with plasma-free hemoglobin, that's a double hit on the kidney. Now, some people say that if you just bolus 2 liters of fluid, you dilute the plasma-free hemoglobin and you're not going to have any effects. But, are we truly going to go backwards to the old thermocool days where we had urinary retention, Foley catheters, giving diuretics? And are we really preventing subclinical injury? Because in fact, when hemoglobin goes into the kidney, it triggers an entire inflammatory response, even in low doses. And that's not going to be helped by any amount of saline that you give the patient. Furthermore, hemolysis also depletes nitric oxide, which can increase the likelihood of vasospasm. So you've probably heard of cases of vasospasm that are now occurring several days after the procedure. This may be a driver of that. And furthermore, as I shared with you in my last presentation, when you deplete nitric oxide, you also cause incredible platelet activation and aggregation, which causes a coagulopathy. And certainly there are huge differences in the amount of hemolysis created by the various systems. And again, the next speaker is going to be talking about that in more detail. So let's go back to designing our waveforms. Let's say we pick 4 waveforms that balance musculoskeletal stimulation with depth of the lesion. The next step is we now have to look at their thermal profile. And as you can see, all of these candidate waveforms are producing about the same depth. But as we start looking at their thermal profile, we see that, for example, waveform D is certainly creating a thermal signature at 3 millimeters below the tissue surface that is in excess of 50 degrees Celsius, whereas waveform candidate A is not producing any signs of a thermal threshold. So again, it's about compromising between efficacy, stimulation, and thermal threshold. Now, we know that all PFA systems have a small thermal reaction at 3 millimeters below the surface. For example, the Centauri system causes an elevation in temperature of about 5 or 6 degrees. Now, fortunately, this is not high enough to cause any thermal damage. And key things like the interphase delay, intertrain delay, and post-delivery delay are essential to avoid stacking that heat signature so that it doesn't cause major problems. Furthermore, one of the reasons why we do repeated bursts of pulses and not just one long pulse is that by giving repeated bursts of pulse, we actually reduce the overall thermal profile compared to only giving one or a few pulses. So repeated bursts help to mitigate that thermal effect. Now, irrigation can also mitigate that thermal effect, but you should not be dependent on this for thermal mitigation. We know that there are a lot of PFA catheters out there that are non-irrigated. So you shouldn't be relying on irrigation. So yes, irrigation can give you a little bit of a safety margin by reducing that thermal threshold. But if you're totally dependent on irrigation, then your pulse parameters are really not well designed. So let me just give you an example of this catheter. This is a catheter that is in development by one of the companies. but they're using an irrigation rate of 40 cc's per minute. So whenever someone tells you that they have a PFA catheter that requires so much irrigation, you know that it's mitigating a very large thermal effect. There's no way you need that much irrigation for a well-designed PFA system. I talked about this with Pulse Select, that you can certainly swage your electrodes or round the edges. And as I pointed out before, look how many different edges they tested to find the ideal rounded edge that would not cause edge effect heating. So edge effect heating is a very important source of heat. And it is also a very important source of microbubble formation. So look at the edge of this electrode and see the concentration of microbubbles on that edge because of heat. And in this very, very nice study that was published by Damian Miklavchik's group in Ljubljana, they showed that with biphasic high-frequency protocols, which is what all of our systems are using, heat is actually the principal reason why you see microbubbles. So if your PFA system is causing a lot of microbubbles, you know that your PFA system is also causing a lot of heat. Now, heating bubbles, thermal bubbles, are not the only origin of bubbles. Bubbles can happen due to degassing of nitrogen. They can occur due to hydrolysis. But depending on the origin of the bubble, that bubble is going to be of a different size and will persist in the bloodstream for a longer period of time. So if you have air or thermal bubbles, those are at risk of causing cerebral ischemia, whereas bubbles that are created by hydrolysis or electrolytic reactions probably resolve very, very quickly and are unlikely to cause cerebral ischemia. I showed this in my last talk just to show you how there can be incredible differences in the amount of bubbles produced by the various systems. Let's talk about coronary vasospasm. We know that if you put a large PFA catheter on the CTI or the mitral isthmus, you are going to be in proximity with the coronary, and this can cause prolonged spasm. Now, a lot of people are saying, well, you know, if we just give huge boluses of intravenous nitroglycerin, then we can eliminate that problem. But these are huge doses which lower the blood pressure. And in order to counteract that, you have to give a vasoconstrictor, phenylephrine, in order to counter that effect. So I'm not sure if this makes a lot of sense. We're giving vasodilators to prevent spasm, but we're immediately following that with vasoconstrictors, and then we're giving vasodilators, and then we're giving vasoconstrictors. I mean, I don't think this is a workable solution for vasoconstriction at all. I would argue we shouldn't use PFA in those regions, period. Furthermore, whenever we do get spasm, we are seeing these somewhat chronic changes, although they are minor. And this has been reported by Ed Gerstenfeld's group, and it's also been reported by Mark Tam's group in Hong Kong, where he looked at it under IVUS. But keep in mind that radiofrequency and cryothermy have been doing this for years, and we don't see progressive coronary artery disease. So while I agree that we should be avoiding spasm and we should not be doing this to our coronary vasculature, keep in mind that it is unlikely to progress into full-blown coronary artery disease. So at the end of the day, all of the various PFA systems do have differences. And I have been very lucky in that I've been able to use almost every single PFA system, either in market-approved settings or in clinical trials. And these are my personal observations when it comes to thermal, musculoskeletal, phrenic, cough, vagal pauses, bubbles, and hemolysis with the various systems. I'll let you take a picture. I'm not going to go through this entire table, but this is just to show that all PFA is not the same. It depends on the design of the individual system. So I'll wrap up here and say that hemolysis is catheter and pulse dependent, but mostly catheter dependent. But myolysis may be an important contributor, and hemolytic effects extend beyond renal injury like spasm and coagulopathy. Thermal effects are present with all PFA, but good electrode design, good pulse design, etc., can minimize the amount of microbubbles. If you see bubbles, that's not a good thing. They may not cause a stroke, but they're an indicator that your PFA is not well designed. And then finally, coronary vasospasm remains a problem. I really think that the long-term solution is really to use RF in those areas. I don't think using high-dose nitro with PFA is really a good solution because A, we're not preventing all spasm, B, we're not preventing coronary damage. And right now, it's more cost than anything else that's forcing us to do this. But I think as the cost comes down, we're going to stop doing this altogether. So I want to thank you very much for all of the courtesy that you've extended me. I'm sorry I couldn't be there. And I look forward to coming back to Prague in person in future iterations. Thank you very much.
Okay, so this was first talk today, and we have another talk about, as you heard already, about hemolysis by my colleague Predrag Stojadinovic, and he will tell you how is it with hemolysis, how much we should worry about.
Okay, thank you, dear professor, dear colleagues, ladies and gentlemen. My task today is to talk about hemolysis related to PFA, and I think this is very important topic because hemolysis is not only specific to the PFA, but it's also specific to the PFA platforms, as we heard. So today I will talk about the pathophysiology of hemolysis. I will show you how to measure hemolysis, and then I will provide some conclusions based on the results from the preclinical and clinical studies. So hemolysis is really destruction of erythrocytes, and there is physiological background for this. Red blood cells have a lifespan of 120 days, and after that they are replaced by the new ones, but in controlled manner outside of the vessels in reticuloendothelial system. And compared to this extravascular hemolysis, we have intravascular hemolysis that is always pathological, and there are a variety of pathological states or that may cause destruction of red blood cells inside the blood vessels. And once hemolysis occurred, hemoglobin will be released and will become free in the bloodstream. And we heard that this free hemoglobin is or can be toxic because it will cause consumption of the nitric oxide, but it will also cause dysregulation of the nitric oxide synthesis, and all of this will impair the function of endothelium, but also the function of the platelets. So this inflammation and irritation of the endothelium, in addition to clot formation, may cause end organ damage. And luckily in humans we have adaptive mechanisms to deal with this hemolysis, and the main role here plays haptoglobin that will bind to this hemoglobin, and these complexes will be transferred and processed in the liver. So hemolysis can be quantified, and there are a variety of different qualitative and quantitative tests that can be used, but from the aspect of clinical practice, I think the most important are these points 4, 5, 6, and 9. And given the fact that extent of hemolysis is the highest shortly after ablation, we need to take blood samples at least at 3 time points before ablation, immediately after ablation, and the next day after ablation in order to catch this peak of hemolysis. And when we measure haptoglobin level, we need to know that we are measuring only the free fraction of haptoglobin that is not binded to hemoglobin. So with bigger hemolysis, the level of haptoglobin will go down. And from the clinical practice, the most important question is what is actually clinically significant hemolysis, because we don't have guidelines for this, we don't have the strict definition, but actually we can adapt the definition from the general guidelines for extracorporeal life support, where significant hemolysis is one when free hemoglobin level is over 500 milligrams per liter. So pulse field energy induces hemolysis, and this is nothing new. Actually, when you see this study from late 70s, the group of authors demonstrated that in vitro pulse field energy of 2000 volts per centimeter induced pore formation on the erythrocytes with iron leakage and cell swelling with subsequent membrane rupture and hemoglobin release. So this is old information. And this is interesting study from a group of authors from Prague, and in this study they evaluated the rate of hemolysis and cardiac cell death during in vitro PFA with different electric field intensities, and they demonstrated that the most effective induction of cell death was observed at 1,500 volts per centimeter, and this intensity was also associated with a significant degree of hemolysis that occurred already around 1,000 volts per centimeters. And although it's very challenging to translate this information into the clinical practice, I think this information can be useful, especially for the companies developing the new ablation systems. But there are also other factors contributing to the extent of hemolysis. This is another study from Prague. Actually, this is the group around Professor Peter Neugil, and they conducted an in vitro experiment, very interesting experiment, where they ablated fresh swine skeletal muscle that was submerged within the heparinized blood, and they were using Farapulse technology for this experiment. And in first group, the catheter was only floating in the blood, so there was no direct contact with the tissue. And in second group, this catheter was sutured onto the muscle tissue in order to ensure the good contact and to prevent muscle flying away from the ball. And they had two very important findings. First, the extent of hemolysis was higher with a higher number of applications, and the significant hemolysis occurred already after 10 applications in this setting. But second and for me, more important findings from this study is that no contact increased hemolysis by 3 times. And this is very important for us doing catheter ablation. So contact is also very, very important. In 2024, Manifest 17K study or registry was published showing a very good safety profile of the Farapulse technology with only few PFA-specific complications. However, there were 5 patients who experienced acute kidney injury that had to be treated by transient hemodialysis. So this is really a severe complication, but it's also extremely rare, And the main problem here was the extensive ablation with many applications, reaching in average 150 applications. This is too much, but what we cannot find in this manuscript is that we cannot find any information about the volume status of the patients. We don't know if they had some hypotensive episodes, and we don't know about the contrast agent administration, because all of these patients had pre-procedural CT with the contrast agent, and these factors also contributed to this hemolysis. This is a study from a group from Texas. They evaluated the occurrence of hemoglobinuria after PFA ablation, and they evaluated its impact on renal functions. They enrolled 103 patients, and in first 28 patients, no post-ablation hydration was used, while later 75 patients had planned post-ablation hydration. And they found out that 75% of patients without post-ablation hydration had hemoglobinuria. They had increased LDH and decreased, very low actually, hepatoglobin, globin, and they had increased creatinine levels. And they also found that hydration and the number of applications were independent predictors of acute renal injury after PFA. So they conclude that acute kidney injury after PFA can be really prevented by post-ablation hydration. This is our study where we quantify the effect of pulse field ablation on erythrocytes damage during AF ablation. So we enrolled 60 patients with persistent AF undergoing catheter ablation using Farapulse system. And in those patients, we took blood samples before the procedure, immediately after the procedure, and on the next day after the procedure, to assess the biomarkers of hemolysis. And following the PFA ablation, we saw that free hemoglobin and LDH were significantly increased after the procedure. And there was a very strong correlation between the peak free hemoglobin and the number of the applications. The major hemolysis was predicted by the number of applications with area under the curve of 93%, and the cutoff of 74 applications predicted hemolysis with a very high sensitivity and specificity of near 90%. Importantly, we have no significant change in renal functions following the procedure, but this was measured the first day after the procedure, and we haven't found any correlation between the peak free hemoglobin and the change of the creatinine level. So this means that hemolysis is not the only factor causing acute kidney injury. So there must be some other precipitating factors to kidney injury. And this is also very interesting. This abstract was actually presented 1 month ago in Vienna during the ERA Congress, and these authors compared the hemolysis after PFA, but by 3 different PF ablation technologies. They use a Farah, a Sphere 9 catheter, they had a pentaspline Farapulse, and they had a variable loop. I suppose this is a Varipulse catheter. And they showed that hemolysis was higher with a bigger footprint catheter used for ablation. And this was true even after adjusting for the number of applications. So the extent of hemolysis varies across different PFA platforms. So these are my conclusions. Pulse field energy induces intravascular hemolysis, and these events are dependent on the electric field strengths but also it's dependent on the contact and the number of applications. Yes, hemolysis can cause renal failure, but these events are extremely rare. And I believe that acute kidney injury is probably under-recognized because we are not routinely measuring renal parameters, for example, second day after the procedure. But these events are usually reversible, and importantly, it can be prevented by post-ablation hydration. And what is important is that we can predict significant hemolysis, and finally, the extent of hemolysis varies across different PFA platforms. Thank you for your attention.
Thank you very much. Before we connect to EP Labs, we can have short discussion. Any comments or questions? Before you get some maybe question or comment, I will take comment, or I will have a comment. These two lectures nicely document that pulse field is not one entity, because often people talk about pulse field like about RF or cryo, and you see that there are not only different platforms, but there are also different risks of complications. And we are obsessed a little bit with effectiveness, but we should be also obsessed about safety. And you can, you could hear that there is a lot of things that have to be taken into consideration when you are using this technology. And every platform should have tests not only for durability of PV isolation, for instance, after 3 months, but also about safety. And we have some signals from different studies and also from clinical practice that there is some risk which might be higher in some platforms and lower in other platforms. And this is also very important because this emphasizes the role of registries, because clinical studies are okay, but they have usually selected population of patients. For instance, the first signal that there is a hemolysis and it could be clinical problem, even a renal failure, came from the registry Manifest PF, which we participated. This was, as you know, a large registry and many centers. And the first signal that there could be a renal failure came from this registry. And then people started to study, like Drag showed you, a lot of studies which were as a consequence of this signal which was sent from this registry. So not only randomized clinical studies, but also registries are very important to follow the patients from real life and see, because also from this registry came out that if you apply like 150 deliveries of pulse field with parapulse, you can have this serious problem. So nobody did this during these pivotal clinical trials. And finally, it's also, for instance, a different thermal effect where you have to take into consideration. So we saw different technologies yesterday. You saw different amount of bubbles. And as you heard from nice talk of Atul Verma, not all bubbles are just due to electrolysis. And if you have these large showers of, or a lot of bubbles, that might be heating of the tissue. So you have to always judge what is the best technology and study all the time the side effects of this technology, because we are so enthusiastic sometimes that we forget about safety. So that's my comment. Any other thoughts or questions? Okay, there is a question.
That was a great presentation. I really enjoyed that. Congratulations. The other question I have, I don't know is easy to answer, but there's one side of the thing is hemolysis. The other, maybe the patient's sensitivity to hemolysis causing renal failure. So do you have any insights as to whether some patients might be more sensitive to free hemoglobin causing renal dysfunction, and because we really care about the renal side effect of hemolysis?
Yeah, definitely patients with pre-existing renal failure or can be more sensitive to hemoglobin, free hemoglobin levels. But there are also other factors, peri-procedural factors, hypotension, hydration, and also this contrast agent, because usually we give this contrast agent 1 day before the procedure, and this acute kidney injury is delayed, like not immediately the second day, but the next day. So these are factors also contributing, and we have to take this into account. And especially if we do extensive ablations, we need to think about hydration after the procedure. So in my opinion, every time I had more than 100 applications, because sometimes we have to deal with complex arrhythmia. We cannot stop only with, and cannot be satisfied only with the PVI. So in those cases, I'm prescribing hydration after the procedure.
One factor which is often neglected is that many people do CT scan, for instance, with contrast 1 day before. I don't see much reason for technology like Farapulse to use CT before. But if you use intracardiac echo, as we discussed yesterday repeatedly, that would you can avoid all this stuff. And if you need a CT scan, you can do it in advance, not just 1 day before the procedure, because then you accumulate possible adverse effects on renal function, especially in patients who have already renal dysfunction. As you know, atrial fibrillation is one factor which decreases renal function, and the drug is running now some research project about the effect of atrial fibrillation on renal perfusion and renal function. And if there is already some evidence that if you do a successful cardioversion or ablation, the renal function is improving in those patients, because there is probably the effect of improved perfusion of kidneys.
Just to be clear, my presentation is about actually the safety of the PFA. So if we do PVI only, we have like 35 to 40 applications with Farapulse, and with that number of applications, we don't have a severe hemolysis. So this is good, and we also have data that cryo is also causing hemolysis, but it's not clinically significant because we are applying only few applications. So this is also important. So my presentation is actually telling you that PFA is actually safety if you know how to use it.
Okay.